Okay, let's talk about something almost every parent or caregiver goes through: a child's fever. You know that feeling, right? You see that number climbing on the thermometer and your heart just sinks. It's instant anxiety. But what if we looked at it in a totally different way? What if we saw it less as just a common worry and more as the start of a complex medical mystery, a case that needs to be solved? Because you see, that's pretty much how doctors look at it. For them, a fever is the first clue. And they have a really detailed playbook, a whole system they use to figure out what's actually going on. So today, we're going to unpack that very playbook, one that was built specifically for the unique medical challenges you'd find in a country like India. All right, so the case file is open. The first piece of intel is in: a fever. And while that sounds pretty simple, this is where a really high-stakes investigation kicks off. And when I say high stakes, I mean it. In a place like India, these guidelines point out something huge. Acute febrile illness, that's fever basically, along with respiratory and diarrheal diseases, makes up a whopping 75% of all emergency visits for kids. So a fever isn't just a common thing, it's very often the #1 reason a child gets rushed to the hospital. Now, this playbook wasn't just, copied from somewhere else. You can't just take Western guidelines and apply them everywhere. They often don't account for the unique tropical infections you find in India. We're talking dengue, typhoid, scrub typhus. So the Indian Council of Medical Research got a whole team of experts together: clinicians, microbiologists, you name it. They spent months hashing it all out to build a guide from the ground up, one that actually works on the ground there. It's a fantastic example of tailoring medicine to fit a local reality. Okay, so the case is open. Our detective, the doctor, starts looking for physical evidence. And the very first question is always, did this fever bring any friends along? Any other visible clues? And two of the most common leads are swollen glands, the medical term is lymphadenopathy, and a rash, which is technically called an exanthem. You can think of these as two completely different trails of evidence. Each one is going to lead the investigation down a very different path. So let's say the clue is swollen glands. The doctor's mind starts running down a checklist. Are they just in one spot, or are they all over? Did they just pop up, or have they been there for a while? A lot of the time it's something simple, like a run-of-the-mill viral infection. But they're also on the lookout for more serious suspects, like tuberculosis or even cancer. They'll even look for clues nearby, like an infected tooth that might be causing a neck gland to swell up. And this is where the investigation can really escalate. A swollen gland isn't always harmless. Its location, for instance, is a huge clue. A swollen node right above the collarbone, that immediately raises a red flag for malignancy. Same goes for a gland that just keeps getting bigger over weeks, or one that never quite goes away. Those are the signs that tell a doctor, okay, this isn't just a simple infection. And that's when you start thinking about more serious steps, like a biopsy. But what if the clue is a rash? Well, that's a whole different puzzle. A rash isn't one diagnosis. It's more like a signpost that could be pointing to a ton of different things. It could be a virus, like dengue, a bacteria like typhoid, or even a really serious inflammatory issue like Kawasaki disease. The doctor has to become an expert at decoding the rash, its type, its location, what else is happening, just to start narrowing down that long list of suspects. And just like with swollen glands, some rashes are absolute immediate red flags. For example, if a doctor sees these tiny red or purple spots that don't fade when you press on them, they're called petechiae, their mind immediately jumps to a life-threatening infection like meningococcemia. Or if there's severe pain or the skin starts peeling, those are alarm bells for emergencies like toxic shock syndrome. These signs mean one thing and one thing only: get to a hospital right now. Okay, but what happens when the trail just goes cold? When the fever is there, but there are no visible clues, no rash, no swelling glands? This is where the investigation gets really tough. The doctor's basically hunting for an invisible enemy. This whole situation has a name. It's called fever without localizing signs. It's exactly what it sounds like, a fever that shows up all by itself, nothing to point to a source. And in these cases, the doctor's #1 priority is to find, or more importantly, rule out, a hidden but potentially deadly serious bacterial infection, or SBI. So how do you even begin to approach that? Well, the single most critical factor is the child's age. It's simple. The younger the child, the higher the risk. A newborn, just days old, with an unexplained fever,
that's treated as a full-blown medical emergency because their little immune system can get overwhelmed in just a matter of hours. As a child gets older, that risk of a serious hidden infection goes way down.
And this leads us to a really fundamental fork in the road for any doctor. It's not just about the number on the thermometer. It's about how the kid looks. Is the child lethargic, floppy, just not themselves? That's what doctors call a sick-looking child, and that means immediate admission and a full court press to find that SBI. But if the child has a fever but is still alert, playing, and generally looking well, then especially if they're a bit older, the approach can be much more about careful observation. Now let's get into the toughest part of the entire investigation. What happens when the days keep passing, then weeks, and that fever just will not break? This, my friends, is the ultimate pediatric cold case, and it has a name: fever of unknown origin, or FUO. The textbook definition is a fever that hangs around for more than 3 weeks, with doctors still having no clue what's causing it, even after a full week of in-hospital tests. This is where the detective work gets incredibly deep. So what on earth could cause a fever to last that long? Well, the potential culprits fall into a few big buckets. Turns out about half the time it is still an infection, just a really sneaky or hidden one. But the other half is a mix of really serious stuff: immunological disorders, where the body is attacking itself, cancers like leukemia, and then there's this frustrating slice of cases that sometimes never get a clear diagnosis. And this is what makes it so incredibly hard. To solve a fever of unknown origin, the lineup of suspects is just mind-bogglingly diverse. I mean, a doctor could be looking into anything from tuberculosis to an autoimmune disease like lupus to leukemia, or even a hidden infection on a heart valve. The investigation just becomes this meticulous, high-stakes game of ruling things out one by one. So we've walked through all these complex pathways and decision trees. What's the big picture takeaway here? It all boils down to a critical balancing act, a dilemma that every single doctor faces. And this quote from the authors of these very guidelines just says it all perfectly. The real challenge, the art of medicine, is right there, in that balance. It's knowing when to go all in to treat something dangerous versus the harm you could cause by over-testing and over-treating a simple virus that was just going to go away on its own. And that is the ultimate goal of this entire playbook we've been talking about. The point isn't just to find the answer, no matter the cost. It's to find it wisely, to protect the child not only from the illness, but from the potential harms of the medical investigation itself. So let's just quickly recap the whole playbook. First, a child's fever isn't just a number, it's the start of a real investigation. Second, visible clues like a rash or swollen glands are huge signposts that direct the search. Third, if there are no clues, a child's age and how they look are the most important pieces of evidence. And finally, the whole time, the goal is that tricky balance. Catch the bad stuff early, but don't overdo it for the minor stuff. It's just a staggering amount of thought and clinical reasoning that goes into what we all think of as a really common problem. So I'll leave you with this question. Knowing all the complexity, all this detective work that's happening behind the scenes, how does that change your perspective on a simple fever?